Piers for allowing me to share some of my clinical realities with extracting retained screws. This is the dark side of, hopefully you can shed a little bit of light on this subject. Because the time is so short, there's a few areas that I wanted to definitely cover on the positive side of how we direct our treatment protocols here to, for instance, a diagnostic algorithm that I've come up with to actually help us get through these issues. But also, we're going to look at some of the specialized tooling that I've utilizing to attack some of the more difficult cases. And, but before we get involved with that, I want to show you what not to do in the case, and I'm calling it Robert's Wreck, because this was referred to me, into me about 2 years ago. Happened to be a 4.1 bone level implant in number 9 position. And the dentist that was going to place a custom zirconia abutment fractured the abutment screw on delivery of the prosthesis. And then panicked, and when he panicked, he got a hold of a fragment fork to try to take this screw out, and unfortunately didn't know how to deal with the situation, and used the fragment fork in a very inappropriate way. And when he did, this is what he proceeded to do. This is how the case came into me originally, and this image comes off of a surgical microscope with a video capture frame. It's one I was borrowing at the time. And it's really hard to get a clear picture of what's going on, so I'll annotate it for you. The yellow dot is really concentric on the implant, and that's the center line of the metric 1/6 screw. And if you, the green line then are the screw threads. The crop circle on the left-hand side is really the damage that was done by this fragment fork. And everything looks off-centered on this implant because what I did was skewed it a little bit in the microscope so you could see the damage on the sidewall of the implant. So the red circle is the damage, and that was created by this bad boy, this fragment fork. Now, you would think, gee, a 1.4 millimeter frag fork on a 1.6 millimeter screw is appropriate, but there's two aspects to this that are a problem. One is fragment forks like this can wander, just like a flat blade screwdriver can wander off the top of a screw. And so this probably wandered over sideways before it started to drill out the implant. And two, the pre-drill size on a metric 1/6 screw is really 1.25 millimeters. So even if this frag fork stayed in concentric on the screw, it would have started reaming out some of the threads. So here's an impression of the stock 4.1 bone level implant and showing the thread crispness. And here's Robert's case. It was, you can see the lack of detail on the threads. Basically, this implant was not restorable. And the fortunate part about it was getting the screw fragment out with appropriate guidance wasn't really that hard. But most of the time, this implant would have been either buried or explanted. But in this particular situation, I think there was another solution. And then here's the frag fork that you can see where the damage occurred. But I elected to take this implant and rethread it into a larger screw size. And that's possible because the metric 1/8 is a big brother of the 1/6 with the same thread pitch. So this is a metric 1.45 pre-drill, and then I tapped it out to 1/8. And now I have an implant that is restorable, but there's no components to restore it with. So we have to make our components to restore it with. So instead of using the zirconia abutment, I went to the Atlantis gold hue titanium abutment, and by getting that back, I could ream the through bore on it just slightly bigger to accommodate the 1/6 screw. And then, of course, now there's no screw that you can buy, so I made the screw in my machine shop. So with that in mind, you have now a gold hue abutment and a restored implant, and it's very robust, and I think it'll work quite well. So what went wrong in this case? Well, the dentist didn't have any appreciation for the implant dimensions or the recovery tooling, didn't know how the recovery tooling could help him, and of course visualization was a real issue. Couldn't see what he was doing, so he didn't know how to stop when things were going south. So looking on the other side of the point of what should you do when you run into these situations? Well, after about 150 cases, I can tell you that pretty much all screw fragments are removable or retrievable. Unfortunately, sometimes they're retrievable in pieces, but most of the time they're retrievable whole if you don't make mistakes. Two questions then become, what happens to the implant in this process? What's left when the implant is deemed clear of the fragments? And two, how much effort has the procedure demanded? In Robert's case, the effort was huge, and, to recover from all this damage, and so it doesn't have to go that way. When evaluating a screw for the first time, a screw fragment for the first time, please realize that it'll never be easier to remove than it is right now. So our first question that we have when a patient calls in about this is, who's worked on it and how much? Because that's going to be an indicator of how much trouble it's going to be for us. And then each effort can potentially complicate the retrieval. So you have to realize in these cases that the dimensions are small in there and the tolerances are tight. So you have to keep that in mind. So visualization in this process is super critical. And it's said that seeing is believing and seeing is truly understanding. And so the operating microscope is an absolute critical key to be utilized in these cases. And the 16 to 25 power range is routine for me. And I'll show you a case in just a moment about how that helps you. And then starting the recovery process on a case, you really have to understand the dimensions that you're working in, the implant interface. You have to know it very well, and you also have to understand your recovery tools, not only how they can help you, but how the recovery tools can hurt you, as in that fragment fork is a very handy tool to use in the correct way, and I'll show you that in a moment as well. But inappropriate, it can really damage the situation. Well, how do you evaluate the difficulty of the problem when you're going into a case? And that's really important to understand. And over the number of cases I've treated, it's kind of boiled down to some scenarios that I'll share with you right now. I call it the diagnostic algorithm, and it goes like this. These screws come in different positions and different mobilities. And so these two diagrams will point out the difference. When you have a screw, it seems to either fracture above the implant threads or below, sometimes right out, and if you have magnification, you can tell the difference. And then there's mobility. Is it mobile with an endodontic explorer or isn't it? So if it's mobile and it's above, those are the ones I don't get to see very often because they've already come out with an explorer situation and they've been retrieved. That's the easiest scenario. If it's non-mobile and it's above, it's retrievable as well, and I've got it in this position because the implant threads are not yet at risk. When you go below the first implant threads, every effort that you make could ding a thread, and once you ding a thread, the screw fragment will not want to come out. So a mobile type 3 is the type 3 below the first thread, and that's kind of a risky condition, but if handled well, it can be easy. And then there's a non-mobile type 4 case, which is the tough one, and you have to be very careful or things can go really south. So let me show you the other aspect to this, and that's where the screw is fractured. The one on your left is a fracture through the neck of the screw, and that really doesn't present much of a problem because the diameter at that fracture is less than the threads. But the one on the right is, and it's fractured through the threads, leaving that burr on the upper left corner, and when that screw wants to come out, if that screw happens to be positioned below the implant, the top thread on the implant, then what happens is that as that screw comes out, lefty-loosey, counterclockwise, that little fragment point will be leading, and it will be impeding progress in many cases. Let me just show you a case really quick with this, and it's Pam's case, and she came in about 6 months ago. Happens to be a 4-5 implant with had a broken direct abutment screw. And the red line is the top of the screw threads. The yellow line is the top of the fragment. And then in her hand, she had the restorative components. And if you really look close at the image on the right, you can see that this fragment, this screw broke right across the screw threads. So there's a sharp corner on it. Going back to our other diagram, you can see that that sharp corner now will be probably a type 3 case, because no one's worked on it yet, so I'm assuming the rest of the fragment's mobile, and it's down below first thread. So here's the image that you would see typically. The angle of view here would be about 2.5 power, maybe up to 4 power loop magnification. You can certainly see the top of the fragment, but you can't see any detail. If you graduate up to a surgical microscope, this would be the angle of view at about 16 power. Now you can see a lot more detail involved in the case. But then if you shoot up to 25 power, now you're talking. You can see this little metric 1/6 screw now looks like about a 3/4 inch bolt. You can see the details on the threads. You can see the details of that little sharp point that I showed you a minute ago. So when that point was at around 10 o'clock, and I started working on it, here's the fragment on the right-hand side. You can see what we recovered with just an endodontic explorer and with a little bit of lubrication. And then the image on the left is blown up here, and you can see after a period of time with the endo explorer, now I'm around to 3 o'clock with that fragment. And after about 25 minutes of careful maneuvering, I was up another 390 degrees. And at this point, this is a junction because this little point fragment is sitting at the top of the screw threads. And so in about another 30 seconds, I'm 180 degrees more, and now we have an open implant and a happy patient, happy doctor, and a happy referring source, and happy implant. So it's ready to live for another day, and there's no damage at all. It could have been disastrous because this was a type 3 that could have gone to a type 4 and could have looked like Robert's case really easily if we didn't handle it correctly. Now, what about the other cases, the type 2s and the type 4s? Those are the ones that are stuck when they come in, and those are more difficult because we're going to have to apply more removal torque to this to get these to go out. And I like to implement a system which uses the least destructive method possible on that screw, because if the more I grind on that screw, the more I take a chance at damaging an implant. So I like to work concentrically on the screw, like to work away from the implant threads and the interface, and I realize that the tooling that's there has to be with very precision tolerance because the dimensions are small and the tolerances are tight. So here's some of the prototype tooling that I've been working with. This happens to be on a 3i 4-3 implant, and the drill is a 31 thousandths drill for a reason, and I'll show you. And then the guide, that drill fits that guide to about 1/2 thousandths of an inch. It's almost like a pneumatic cylinder. And when you blow it up, you can see that that drill fits very, very concentrically into that implant. And this is what I routinely do on a case when I have any implant system. I'm going to open up an analog and take a look and see what we've got, because you have to know these very well. This is a screw fragment that came out with that in this case, and you can see that the screw was able to Robin Hood that drill was able to Robin Hood that screw right down the middle, and then we were able to mobilize it with a frag fork. This is the frag fork that was used. It's a 1mm frag fork, as Marlon knows quite well. Every now and then I'm asking for a couple. And this hole is 31 thousandths of an inch. And so I'm taking advantage of those sharp corners on that fragment fork to work its way into that 31 thousandths hole. And by doing that, I'm gaining some significant traction on the case and gaining some real advantage to pull those out. And we've taken out some very tight screws doing that without having to get involved with taking the whole body of the screw out and then start working taps onto the threads. Now, just to summarize that removal technique on the 2s and 4s then, in conclusion, what you want to do is you want to implement a system. I've showed you a system that uses drilling and distracting the fragment or extracting the fragment. Tools with precise tolerances have to be used, and dimensions are smaller and tolerances are tight, so keep that in mind. There isn't a lot of tooling out there. That's why I'm still working on the prototypes that I've got. Just to let you know, any tools that you might see, there are some around for various systems, but please evaluate them very carefully. I've kind of rejected most of this stuff. All right, thank you for your attention, and I think we just about did.